And now it's over to Dr. Irfan Karamat.
Thank you very much. Bismillahirrahmanirrahim. I'm Dr. Irfan Karamat, and the next session is on stem cell in ophthalmology. Uh, I would like to. I'm first of all, I'm really thankful to all my senior colleagues and all my teachers. They are here, and I'm really honored that they are here and attending this session. I would like to introduce Dr. Shazad Anwar. He's interventional pain and spine and pain physician. I'm really honored that he has he's here today, and he's going to talk about stem cells and let us know that how this new era would change ophthalmology, inshallah, in coming years. Please, Dr. Shadad, can you please come and share this session? Yes, please. I would introduce him a bit. Dr. Shazad Anwar has done MSc in pain medicine from UK. He is diplomat pain medicine from Howard University, interventional pain medicine. He is diplomat American Board of Regenerative Medicine. He is currently working as CEO in Ifatan Hospital. He's head of department of pain medicine in Azra Nahid Hospital. He is president of Society of Interventional Pain Medicine. He is president of Regenerative Society of Pakistan. Today, this session is about how stem cell can help us in ophthalmology to treat some untreatable diseases. Our 1 hour session is divided into 2 sessions. Dr. Shadad will be talking about how these stem cells are working and how we can harvest them. And I would be just linking them with ophthalmology. We would be sharing our work from past 1 year, that how we are working, and this is we would share our preliminary data as well. And this session is basically just to introduce you guys and to let us know and help us, and let's work together and explore new eras, inshallah. I would not take more time, and I would request Dr. Shahad to come and start his proceedings. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so very much, Dr. Irfan. And thank you all who are sitting here, especially Professor Hamid Bhatt. I mean, I was there when he was our associate professor in Allama Iqbal Medical College. And yes, sir, you have always been an icon and a person to look forward to always. So this is the topic overview of regenerative medicine, especially PRP and autologous stem cells. These are my disclosures. I'm owner and CEO Ifat Anwar Medical Complex, a 100-bedded facility, head Department of Pain and Regenerative Medicine at Azra Nahid Medical College, Piri University, Lahore, faculty and examiner for World Institute of Pain, USA, faculty member, Pain School International, Budapest, Hungary, faculty member for National Academy for Endoscopic Spine Surgery, Turkey. I'm also founder and serving president of Society for Interventional Pain Medicine, Pakistan, and also the president. I've got no financial disclosures regarding this talk. So what is regenerative medicine? Regenerative medicine, National Institute of Health, USA defines regenerative medicine as the process of creating living functional tissues to repair or replace tissue or organ function lost due to age, disease, damage, or congenital defects. So all those age-related chronic diseases, neurodegenerative conditions, neurodevelopmental conditions, we can help with regenerative medicine. This field holds the promise of regenerating damaged tissues and organs of the body by stimulating previously thought irreparable organs to heal themselves. There are 2 basic branches. One is the cell therapy we as physicians are concerned with. The other is the tissue engineering. Right? Evolving applications include but are not limited to osteoarthritis, degenerative disc disease, autoimmune conditions including rheumatoid arthritis, ophthalmology, macular degeneration, retinitis pigmentosa, glaucoma, optic nerve atrophy, then regrowth of organs and tissues like skin, bladder, liver, kidney, pancreas. Vascular indications include intracardiac and peripheral injections, peripheral nerve and spinal cord injuries, burns, skin regrafts, craniofacial and plastic reconstruction, breast reconstruction, Neurodegenerative conditions include Parkinson's disease, dementia, Alzheimer's, and for neurodevelopmental, we are working with CP and autism. What happens with aging? Aging causes an imbalance between the repair work which is going on and the breakdown. With aging, the breakdown takes over and the repair work gets, that's how we get aged and the things get degenerated. Right? So what the basic principle of regenerative medicine is to shift the balance from degeneration to repair and regeneration. Regenerative medicine is a hot topic. We can see that during the 2021, 14,000 plus reference were published in PubMed, and there were more 248 systemic reviews and meta-analysis. This is, you can see from 1920, there is huge rise in the studies and the publications for regenerative medicine, and similarly same for the stem cell therapy. So the most basic thing we can do with regenerative medicine is platelet-rich plasma. Platelet-rich plasma is the blood plasma that has been enriched with platelets. As a concentrated source of autologous platelets, PRP contains and releases through degranulation several different growth factors and other cytokines that stimulate healing of bone and soft tissue. So basically, we are stimulating the healing process of the body itself. This is what we do is we take the whole blood, centrifuge it with specific parameters, and then we get three things. The upper 55% is the plasma. Then this 1 to 2% is the Buffy code. This is the main thing which we harvest and then we stimulate. And then rest of the 45% is the red blood cells. So there are two types. This is very important. Many of our colleagues are using PRP, but they have no idea what is leukocyte-rich PRP and what is leukocyte-poor PRP. Leukocyte-rich PRP is which contains leukocytes or white cells above baseline. What that does is that contains What that does is it contains catabolic cytokines such as interleukin-1 beta, tumor necrosis factor, and metalloproteinases, and they have more catabolic effect rather than anabolic or stimulatory effect. So we should not use PRP in certain conditions where there is already angiogenesis and there is increased vascularity. There we should not use leukocyte-rich PRP. We should use leukocyte-poor PRP, which is contains less leukocytes as compared to the baseline. So this is what we mostly use, and we should know the difference, and we'll tell how to prepare it. Right? Efficacy again depends on the concentration and the composition of the releasate, what is going to release in the body. Optimal concentration for angiogenesis, which is the basis for the regeneration and the stimulatory effect, is 1.3 to 3 million platelets per microliter. Inhibition does happen if the count is more than 5 million. So it does not, I said one thing is leukocyte rich and the other is more concentration of platelets that will inhibit rather than stimulating the regeneration. No point of care PRP system which are commercially available can attain. So, but this can happen with using simple test tubes which most of the people are using. But when we use some stuff which are commercially prepared, which is available freely in the market, that will not take that PRP level to that will inhibit. So just using simple glass or plastic tubes, that can take the PRP count much, and rather than getting the stimulation, will get the inhibition. So no effect if less than 500, less than microliter, then there is just giving the platelet poor plasma. But now the studies are showing that even injecting platelet poor plasma can help because it contains structural proteins which helps to regenerate matrix formulation. So the growth factors include platelet-derived growth factor, transforming growth factor beta, fibroblast growth factor, insulin-like growth factor 1 and 2, vascular VEGF, epidermal growth factor, IL-8, keratinocyte growth factor, connective tissue growth factors, and many more. These are the major ones. How does PRP work? The healing is regulated by complex process using growth factors and cytokines. Platelets are a rich source of bioactive models. There are more than 1100 proteins, both structural and chemical. The exogenous introduction of growth factors may enhance tissue healing in compromised situations. Alpha granules, which are responsible, that TGF-B is for cell replication, VEGF for angiogenesis, platelet-derived growth factor for tissue remodeling and cell replication, that endothelial growth factor for cell migration and replication. So these are the four major granules. Acute inflammation in a controlled manner leads to collagen deposition and enhanced tissue repair. So how do we prepare? We use this harvest system. They have their own specific, which is compatible with this system. We can also use other models as well, but this is the best one can use. So this is the kit. This is the centrifuge. This is, we take the whole blood and put into the centrifuge. We can either have blood in two kits and put it opposite, or we can balance it by putting the normal line in the opposite side. So centrifugation should be in a good manner. So then we centrifuge at around 1800 revolutions per minute. And the key is that we should use a centrifuge which should have a soft acceleration and a soft deceleration. Because if we use rapid acceleration, which is normal Chinese available in the market, but when it starts randomly, it damages the cells and we don't get the good buffy coat. Similarly, when it decelerates in a rapid manner, same happens and we don't get the good. So it should be a soft acceleration and a soft deceleration. And then this is how we get in this separate chamber, and this is the area we collect. Using the needle and all this, right? And the rest is discarded in the blood and all this. Then another thing is photoactivation. Photobiomodulation or photoactivation is the use of monochromatic light. Monochromatic light means light having single wavelength, right? We usually use red wavelength, that is around 640 to 680 nanometers. And what it does, we put this is Eddy-stem stimulator, and we put the PRP and the buffy coat in this and light it for 10 minutes. What it does, we all know with aging mitochondrial dysfunction happens, and the mitochondria is the energy storehouse where ADP is converted into ATP. In all chronic conditions, this ATP formation is compromised. And the basic at cellular level, what happens is a bond is created between cytochrome C oxidase and nitric oxide. So what the light photons do is they break the bond between cytochrome C oxidase and nitric oxide. Nitric oxide is released extracellular, and intracellular there is formation of ATP and cells start to self-heal itself. Though not related to ophthalmological conditions, but just to show you, this is a young patient with roadside accident and fracture of the little toe with gangrenous formation. And he came to us after 6 weeks of the injury, and surgeon was planning to amputate it. We just and he didn't want it. So he was referred to us. So we treated him with PRP and photo. You can see that whole this gangrenous formation. And what we did was we injected PRP and treated with photobiomodulation. And you can see within 6 weeks, not only the finger was saved, but he had all the movements, right? And now coming to stem cells. Any questions regarding PRP? Yes, please. Sir, normally सेंट्रीफ्यूज का प्रिंसिपल तो वही है, बट द थिंग इज कि जी हमने वो सेंट्रीफ्यूज यूज करना है जो मतलब सॉफ्ट स्पिन हो, दैट कैन बी यूज, उसके लिए मतलब दैट कैन ऑल्सो बी बॉट, लेकिन उसके लिए ज़्यादा आसान हाल ये है कि जो हमारी फाउंटेन एलईडी लाइट्स नहीं होती लगी हुई, आपने देखी कि जो डिफरेंट कलर्स की लाइट इमिटिंग डायोड, देयर आर टू टाइप्स ऑफ मोनोक्रोमेटिक लाइट्स. वन इज laser, that is light amplification by stimulated emission of radiation, soft lasers. The other is LED, light emitting diode. Light emitting diode is much cheaper and more practical for us. We can take any LED bulb which emits, which has diode, and we can put that PRP for 10 minutes and stimulate that.
ये इसमें से स्पेसिमेन कलेक्ट किया है, आरबीसीज आपने डिस्कार्ड कर दिए, जो प्लाज्मा था वो भी आपने डिस्कार्ड कर दिया, वो दरमियान वाली चीज जो बफर
जो दरमियान वाला 2% है, दैट इज व्हाट वी टेक, के वो बफी कोट है, दैट फॉर्म्स अ जेल लाइक स्ट्रक्चर, के वो बिल्कुल वहाँ पे ग्रेइश सा या ऑफ वाइट सा क्रीमी, वो बिल्कुल आरबीसीज के ऊपर बैठा होता है, और प्लस अ बिट ऑफ प्लाज्मा. नाउ वी आर नॉट डिस्कार्डिंग द होल प्लाज्मा. We are taking almost whole the plasma because new studies have been published recently that contains cellular structure and protein which are important for matrix formation. So we don't only need to stimulate the cellular healing, we also need matrix there. So we are now using the plasma and the buffy coat both.
Thank you.
So, but we don't use RBCs because they have inhibitory and pro-inflammatory effects, especially when we are injected in the joint or in the disc. Then we have to be very careful, or when you will be injecting in the eye or where there is possibility of angiogenesis, don't ever use light red colored PRP. It should be off-white or pale in color.
Thank you, sir. Thank you.
Right, now the stem cells. So what is a stem cell? Stem cell is a blank cell, and we all have exactly those stem cells which Hazrat Adam and Awwa had. They have not been, unme koi change nahi hai, koi usme mutations nahi hai, so everything is there. They have two specific properties. One is they can self-renew. They can go through multiple divisions, giving rise to their own daughter cells. And then they have asymmetrical division where they produce one daughter cell, exactly copy of them, and then one mature cell going through progenitor, and this is asymmetric cell division. So a stem cell is a blank cell which has the ability to reproduce itself time and again, and also have the ability to go through asymmetric cell division where it produces one daughter stem cell and one specialized stem cell. So types of stem cell, there are so many different ways to classify them, but major ways are differential potential and the origin. The classification according to differentiation is totipotent stem cells. Can anybody tell me the example of a totipotent stem cell? When ovum from the mother is fertilized, and it goes through first few divisions before the stage of forming of blastocyst inner mass, this cell is a totipotent stem cell. It has the capability of forming both placenta and the fetus, right? So that is the totipotent stem cell. Then pluripotent stem cell is the stage where we take cells from this inner mass of the blastocyst. It can form all the three germ layers, endothelium, mesothelium, all these layers, but it cannot produce the placental cells. So this is totipotent. Then we have pluripotent cells. It has the capacity and theoretical capability to form all the three germ layers. Then We talk of multipotent stem cells. Multipotent stem cells are present in every living human being, in every living tissue. It has the capacity to form specific cells of certain lineage. Like if we talk of mesenchymal stem cells, they will form all those cells which are related to mesoderm. Then hematopoietic stem cells, we talking of that all that blood lineage and all those things. And similarly, then we talk of oligopotent cells. They have the limited capacity to form only one specific lineage, either from mesoderm or hematopoietic stem cells, right? Then the unipotent stem cell is the cell which is committed to form only one type of tissue. So totipotent, pluripotent, multipotent, this is the one which we are using, and we are using autologous stem cells. Then oligopotent and the unipotent, right? Then according to from origin, we talk of embryonic stem cells. Again, there are so many issues, ethical issues, how to take from the embryos, or so this may be some studies going on, but now the shift, all the shift is to the adult stem cell. There are no ethical issues, no religious issues. You can be donor for yourself. You don't have to take from it anywhere else. And then there are also preparations available in the market from umbilical cord derived stem cell. But the issue is, if that cold chain is not preserved at minus 180 degrees, they become ineffective within seconds. Right? So now coming to adult stem cells, we can harvest adult stem cells from three sources. Most earliest one were from bone marrow aspirate. We can take it from iliac crest, from tibial, and then the next one is the adipose derived stromal vascular fraction. We take it from the paraumbilical fat or hip fat or thigh fat, anywhere we can take it. And then most convenient and most modern one is the peripheral blood derived very small embryonic like stem cells. And out of these three, these two are multipotent, that they can have one specific lineage, but these peripheral derived stem cells, VSCL, are pluripotent, and they can generate potentially all three germ layers. These are some specific properties: self-renewal, that they can give birth to daughter cells and maintain their potency. Then specific lineage, and then multi-drug resistance. What they do have, their cell membranes have ATP binding cassettes that can actively export organelles or organic molecules out of the cell. So this is very important to use for creating new drugs and creating multi-drug resistance diseases. And then under specific conditions, if we there have been studies shown by Germans that they put mesenchymal stem cells in knee joint, and after 6 months or so, those patients who were diabetic, their glycemic levels started improving. Somehow those cells, they home to the pancreas and stimulated the cell of pancreas, and also improved the sensitivity of the insulin receptors, which become ineffective primarily in type 2 diabetes. I will go briefly through the peripheral blood derived, which we are using for our study, which we are combining with Dr. Irfan Karamat for all the eye conditions. Very small embryonic-like stem cells, VSCL, represent a population of extremely small non-hematopoietic pluripotent stem cells. Their size is around 4 to 5 microns only. And they are negative for all the hematopoietic and express SCA1 in mice and CD133 in humans. Their embryonic characteristics include expression of markers for pluripotency, the ability to give rise to cellular derivatives of all three germ layers, and ability to form embryoid-like bodies. Then after tissue injury, this has been proven that including acute myocardial infarction, bone marrow derived VSCLs are mobilized into peripheral blood and they home to the damaged, and in case of MI, they home to the myocardium. So this is, homing is the one factor which inhibited us by doing that, which fancy work which was initially was being done by Chinese and Indians, that they were going intracranial, they were going intrathecal. What we are doing is we are doing is intradiscal procedures, intra-articular, because they have very absolutely minimal blood flow. That is one reason we have to go into these tissues. Otherwise, if we give IV infusion, these mononuclear cells have every capability to home to that diseased or inflamed tissue, which are producing signals in form of cytokines and chemokines, and they attack to that tissue and home there. And they are so small that they cross both blood-brain and blood-CSF barrier. So there is no need to go for fancy things. We can give IV bolus, or we can give intra-articular, or even in those tissues, Dr. Irfan will explain all those routes. So this is one proposed mechanism of formation of VSEL, that these cells, they give rise to VSEL, which produce mesenchymal stem cells, hematopoietic stem cells, endothelial progenitor cells, and tissue-specific stem cells. And then there is a imaginary thing that there is a intermediate hemangioblast which give rise to HSCs and EPCs. How we do this? So this is the normal concentration of this PBD VSELs in the normal bone marrow, and this is with peripheral blood. This is too low. If we try to harvest from a normal person without giving any, we will not harvest anything. So for that, what we do is we use this filgrastim, which is a colony stimulating factor, and is commonly being used in all those patients who undergo chemotherapy or radiation therapy. It is given to them, so it's very safe to give. So what we do is we use 1 ml of filgrastim subcutaneously for 4 to 5 days, and then we harvest the cells. This is the evidence. When we give the colony stimulating factor, this is the average 0.6 to 0.7, and then on 4th to 5th day, it goes as high as 30 cells per microliter. So it increases by multi-hundred times more. So what it does is it migrates the mononuclear cells from bone marrow to the peripheral blood, and that is where when we harvest them. Patients report on the day of the stem cell therapy procedure. They are advised to take more fluids, water and juices. IV line is secured with an 18 gauge cannula and a 16 gauge needle, which is attached to this stem cell kit, which I will be showing. That is taken in another vein, and this is used for stem cell procedure. So what we use is we use a MCS plus multi-component system by Haemonetics. The blood components are separated using Latham Ball centrifugation process. The stem cells are within the blood cell, the white blood cell layer of the cells, right? So all the mononuclear cells are within the white cell layer. Once stem cells layer has been collected, the device returns the so it's a very simple procedure. Take IV line on the other side just to secure the IV line, and then we take 16 gauge cannula with the kit. And what it does, it takes about 150 to 200 ml blood, process it, separates the mononuclear cells and the buffy coat, and returns rest of the blood to the body, right? And along with this, we use ACDA, not heparin or anything else, so it should not clot. So this is the system we are using. Haemonetics multi-component system. This is available, costs a fortune, right? And this is the kit which we use. This collects the plasma, then buffy coat, and there is separate kit that collects the actual product of mononuclear cells. This is how we do it, peripheral line, and the blood is taken. This ACDA infusion is also attached. It goes along with when the blood is returned. It does not coagulate. This is the Latham Ball, and it takes about 2 to 3 hours maximum. This is the centrifugation. This is the Latham Ball, and this is where we get the mononuclear cells. Right? This is one study published in 2012. It's not new. This study demonstrates that human very small embryonic-like stem cells are able to generate human bone tissue in a mouse model of skeletal repair. This is one of my cases. This patient presented to us with non-healing fracture of C7 spinous process. We injected locally around the injury and also IV, and this is on CT. We can see, and then this is this was in June, and this is 4 months after the treatment, and you can see this is completely healed. This is another patient of mine. I'm sorry I don't have patient to show you eye people, but this is my area of specialty. So this is another patient with huge disc bulge and impeding cauda vena. Impeding cauda vena means that ball bladder reflex is going to diminish in a few times. That patient was unfit for surgery. We had no other option. What we did is first we did a plasma coblation nucleoplasty, intradiscal procedure where we go into the disc and use high energy radio frequency to ablate the disc material in the center and reduce the disc volume by 20 to 25%. And it shrinks. Then we injected intradiscally stem cells, and after a year, 11 months, 1 month after this plasma coblation nucleoplasty, you can see there is decreased dehydration. Dehydration means it's degenerated disc. This is hydration, these are healthy discs. This is nucleus, which are lots of fluid. So this is degenerated. And here we can see that not only the protrusion is gone, but also this hydration has improved as well. Yes.
Yes. Have you got any experience of that? No, when you inject the stuff, it causes healing of the. You just showed the loss. There's a deficiency there. Now my question was a very silly question, but I just want to know. I just want to know that does it cause any fusion? If the process goes beyond your designs, or when you inject it for example, in the knee joint, does it cause any ankylosis? Does it go beyond your expectations? All right. So this. Right. So it is very specific then.
Very specific. And the worst thing is it's not gonna benefit, it's not gonna harm.
Right. Do you have any experience in degenerative arthritis, particularly? So, particularly the knee joint. That's a very big problem.
This is your answer.
All right. Okay.
Right? So this is we have grade 3 plus bone on bone, and we injected intra-articular PRP and stem cell, and here you can see this space and cartilage is growing. And this here we can see before there's a lot of inflammation, fluid there, and now there is more thickness of cartilage, both up and down. So
Excellent. Excellent.
Right. This is for cosmetics purpose. I don't do it. My cosmetology does it, but we prepare the set. So what is the way forward? Way forward is we need to learn from others and from our own experiences and mistakes. Integrate all possible modalities with good and promising evidence for treating different diseases, especially generally thought to be untreatable. Right? My firm belief is there is no disease for which Allah Almighty has not provided us the cure. We simply have to try and to discover it. So this is one short video of 90 seconds. We are lucky to have the only biosafety level 2 lab in Pakistan in a private sector, and we'll show what we have. This is a regenerative medicine lab at Ophthalmology Medical Complex. So this is outside the entrance. All the shoes are take off. Can you stop? Just take it. So this is the passport. So everything which is going there for the sample is taken either in the room for peripheral blood, and if we do liposuction or plastic surgery, that is done in the theater. Even for bone marrow aspiration, that is done in the theater. So though every sample will go through this passport. And that it should not take any contaminants with it. When we put it in, we have infrared light in it, and then the negative pressure. So anything that is contained on the surface, that will be flushed off. Then we have all this negative pressure. This is where from the air is taken from the ground, and then it goes through the HEPA filters, and it's HVAC modular system. And so we have 4 barriers. It's not that you simply go and enter into your workstation, right? Then after 4 barriers, this is the area which is the work area. This side one is for the research purpose, and this one is for clinical purpose. And then we have all those refrigerated centrifuges, this CO2 incubator. Again, this is with HVAC modular theater. So, I mean, this is again refrigerator, and then we have inverted microscope, then cell counters, everything. So we are trying to do it in best possible manner, right? So patient should not have any. This is where our research scientists and all they work here and do their stuff. But that is again, so one passport, and then the second one is, so no infection, nothing. We have done over 5,000 cases of regeneratives, including different diseases. And Alhamdulillah, so far, we haven't encountered one infection or one rejection. Sir, it's in Lahore, Wada town, Punjab Society. Very near to Shah. So thank you so very much.
And Irfan for introducing this forum to OSP.
Thank you, Dr. Shizad, for teaching us arthritis today and showing us all the MRIs. That is where I came in. I met him, and we had a long discussion, and then we had got an idea that why not we try it in ophthalmology as well. So अगर कहीं पे मैं बोर कर दूं तो मुझे काइंडली बता दीजिए. Just a brief sum up. डॉक्टर शिदात ने जो अभी बताया कि regenerative medicine is basically stem cells. Stem cells are adult stem cells, embryonic stem cells. Both can give us certain growth factors. Those growth factors or proteins, what they do, they create a microenvironment. That microenvironment is helpful for a group of cells or tissue to perform its normal function. That is what we just had from Dr. Shah. Stem cell is a cell which has a capacity to renew itself and regenerate adult mature other cells as well. So far, what we take from a stem cell, that it goes and it replaces other cells which are dead there. But we never thought about self-renewal. Basically, what we are working on is its self-renewal capacity. That it that microenvironment can help us to heal those disease cells which are already there, and they can start working forward. We have a definition of embryonic stem cells just by Dr. Shazad, adult stem cells, and induced pluripotent stem cells. Again, these three type of cells, what they do, they produce growth factors or trophic factors or interleukins or proteins which create a microenvironment. Different sources, the most common sources or the most famous source in adult is peripheral blood or growth factors from peripheral blood. That is the easiest way to get it. Embryonic, why we are not working on embryonic stem cells at the moment? Reason being that it can be teratogenic, it can cause inflammation. There are ethical issues in it. So the simplest way to start with in Pakistan especially is to get an autologous source, that is the peripheral blood, and from there we can get it easily and comfortably. So mononuclear cells. This is a study which showed that this mononuclear cells has the capacity to regenerate or to replace or to form into different cells in the body, especially neuronal cells, which I just mentioned. This is how we are, just Dr. Shazad mentioned that how we are separating mononuclear stem cells. Blood is taken from the patient, collected in a disposable kit. The whole blood is divided into blood cells and plasma.
This is the BRP and Buffy.
Yeah. Now from these blood cells, we are separating.
This is the final product.
That you can see a yellow top cell, a layer of yellow cells above the red cells. That is the basically mononuclear cells from where we can extract, and that is the part which we inject through different routes in the eye.
How much blood is taken?
Almost in the process we use 150 to 200 ml of blood. But
Totally, it depends on the patient size and the size of the peripheral rays. Usually we process around 2,500 to 3,000 ml. But at one time it's only about 200 ml that is aspirated. Then it stops, it does the whole process, separates the different components and sends the rest of to the bottle. So then the total volume is around 3 liters, but at one time 150 to 200.
And what
So
we
total time is about 3 hours.
and once we extract it, the rest of the blood goes back into the body.
In one cycle, but we do 12 to 15 cycles. Blood volume is like 4.8 to 5.
So 5.5 liters. Yeah.
But outside the body at one time is maximum 200. Rest is returned back. So only 5 ml of that mononuclear cell is kept, 2 to 3 ml of buffy coat is kept, rest 290 ml is returned back. And then it's again taken, and so the whole process is done. And one cycle is this 200 ml cycle is around 5 to 10 minutes.
So once we got
कि वो सेपरेट करता जाता है ना, किट में वो बैग्स में लग रहे होते हैं, जैसे अभी इरफान ने दिखाया कि वो देखिएगा 200 ml तो बफी रिपोर्ट है, वो जो अगली साइकिल का आएगा वो भी उसी बैग में आएगा, उसी किट में आ जाएगा.
So we got a source, we got mononuclear cells or growth factors. Now how to administrate it? That was the major question which I started studying. And what I got that there are 4 different routes which have been so far tried. Intravitreal. Sir.
How to transport it from your lab to the clinic?
Should I answer it? We do it in a single vicinity. If we go from mononuclear cells, we go into and second, there are 2 sources. I'll come up. जो हम नेक्स्ट वीक में डिस्कस करेंगे. अच्छा, intravitreal, subretinal, suprachoroidal, and subcutaneous. These are 4 different routes which have been so far experimented in different hospitals to administrate stem cells. Intravitreal and subretinal, the studies so far have shown that there was a study published in 2021 in Retina that they tried 14 patients, and out of those 14, 8 patients got retinal detachment, 3 patients got falsified, and only 1 patient had improvement in his vision. So out of 14, it was a study with a lot of complications. Same is the case with subretinal, that it causes extensive epiretinal membrane formation, subretinal fibrosis, and a lot more. So whether or not patient is getting any benefit, there are a lot of complications there. So these two routes are quite are the routes which are quite full of complications. So what we thought that we should go for suprachoroidal and subcutaneous. Suprachoroidal is a route in which there's already a technique which is known as Lamelli's technique, in which there's a window of 5 by 5 millimeter is formed in infratemporal quadrant, in which once it's a similar way the way we make a window for trap. We make a 5 by 5 window. We pick up the sclera and we take some of the fat tissue from the patient, orbital fat, and we impregnate that flap under. We put that adipose tissue under that lamellar flap. Again, it is known as Lamelli's technique. It's there. It's already in the. Again, it is known as Lamelli's technique. It's there. It's already in the. It's published. Lamelli's technique is being practiced for past 3 to 4 years to give steroids, stem cells, and PRP or growth factors to the patients. ये fat derived, जो orbit से ही आप. But again, it's quite invasive. It's quite invasive. You cannot try. Everybody cannot try. There's a learning curve for this. Does it affect? Does it have any positive effect on patients with retinitis pigmentosa? There was a study published in 2020 in which it was shown that suprachoroidal administration of umbilical cord derived mesenchymal stem cells has a beneficial effect on best visual acuity, visual field, and multifocal ERG. This got published in 2020. Now, the 4th route, subcutaneous route. सुनने में भी ये feels like that. Does it work? Can stem cells or can growth factors can pass through sclera or not? Yes, they can pass through. There was a study done by Jarosky in 2001. He showed that growth factors act via tyrosine kinase receptors, which are present at perilimbar region, extraocular muscle insertion, uveoscleral tract, around optic nerve. These are the 4 sites at which receptors are already there, and from there, these growth factors or stem cells can pass through sclera. But the only problem is that whether their size is less than 75 kilodalton kDa or it's more than 75. If it's less than 75 kDa, it can pass through the sclera passively. But if it's more than that, they need electromagnetic iontophoresis. What is that? We have to create an electromagnetic, what you can say, field. That field. How does it help? It gives a charge to the scleral surface, and through that charge, the certain or growth factors or anything that we want to get transported from sclera, it can pass through the help of that electromagnetic iontophoresis. I was lucky that I was working with Professor Amin Usman in 2021, who developed this magnovision. What is magnovision? Magnovision is basically an electromagnetic head cover which gives an electromagnetic stimulation to this local area, and it helps to create and it has to conduct certain stem cells through the sclera. जो उन्होंने जो concept इस्तेमाल किया, that is REMS, repeated electromagnetic stimulation, which is being practiced in neurology to treat depression, schizophrenia, and epilepsy. With the help of this electromagnetic stimulation, what we can do that we can just charge the sclera, and after charging it or giving it a stimulation for like 15 minutes, all the growth factors which have the size greater than 75 kDa, they can pass through sclera easily. So Magnovision is already being FDA approved. It is in the market from 2022 or by 2023. What we started that we tried to copy it here in Pakistan, and we developed our own gadget which is similar to Magnovision, which is working on the basis of REMS, that is repeated electromagnetic stimulation. That is according to the WHO recommendation that the frequency should be that is it's already been published that frequency should be less than 40 to 50 hertz, and the strength of electromagnetic stimulation should be less than 2000 Tesla. That is the WHO recommendation. अगर आप कोई ऐसी चीज दे सकें तो that is human friendly. On the basis of this, Magnovision is working. There was a study published in 2020 which showed that management of retinitis pigmentosa with PRP with combination with electromagnetic stimulation, and it showed that there was a 3 to 4 step improvement in the visual field and multifocal clarity in these patients. There's a comparison of suprachoroidal and subcutaneous stem cell delivery method in patients with retinitis pigmentosa, and it showed that both routes are equally compatible or equally working for the patients. Another study showing, which got published in 2018, same by Professor Newell, that subcutaneous injection of autologous growth factors or PRP on visual field function in eyes in RP cases. It showed improvement in visual acuity, visual field, and multifocal clarity. So I took retinitis pigmentosa as an example in this presentation so that I can make you understand that how it is working. Retinitis pigmentosa is out of the long list of retinal dystrophies. It is almost hitting 2 million patients all over the world, especially the young lot, and it is giving psychological and socioeconomic burden as well. Normally, retinitis pigmentosa is a disease of outer retina. Outer retina, that means RPE, rod and cones. So we are focusing on RPE in our rod and cones. RPE's normal function is that it produces ATP, gives visual acuity proteins, and it manages waste products and give rise to healthy rod and cones. And what we have just learned that this RP is doing all this with the help of growth factors, and all those those growth factors is creating a microenvironment, and RP is performing its functions. What if these growth factors are not there? Healthy rod and cones will go into a dormant rod and convert into a dormant rod and cones for some time. And if we do not give them again that microenvironment, there will be a process of apoptosis and they will die. So this is a typical microscopic picture of RP patient in which there's a degenerated outer retina, and in the presence of this degenerated outer retina, 30% of ganglion cells are intact, 70 to 88% of inner nuclear layer is intact. What if we if we give stem cells or growth factor or microenvironment to these dormant rod and bones? They will start, if we give any growth factors or stem cells to these dying rod and cones, the inner layers are intact. So what will happen? They will start working again. It's a normal theory. कि अगर हम इनको एक माइक्रो एनवायरनमेंट दोबारा दे देते हैं तो जो इनर लेयर्स इंटैक्ट हैं वो दोबारा फंक्शन करना शुरू कर देंगे. दिस इज व्हाट द बेसिक थ्योरी वाज एंड इट वर्कड. Our pilot study was to first pilot study was about the mononuclear cells that we separated. We had 10 patients on which we tried mononuclear cells. The basic procedure was that we had 2 sessions of acupuncture on systemic acupuncture, and after that we gave them subtenon mononuclear cells. The mononuclear cells was we simply did a pericomy, and we went into posterior subtenon space. We injected 2.5 to 3 ml of 1.5 to 2 ml of mononuclear cells. The strength was almost again, which Dr. Shidar mentioned, was 5 to 6 million of stem cells in 1.5 to 2 ml of mononuclear solution. Initially, we had 10 patients. The exclusion inclusion criteria was not that strict because this was something new. We were trying. We took a consent from the patients. Patients' visual acuity was between PL positive to 660. There was extensive visual field loss, and we tried not to take patients with cataract, glaucoma, or other systemic diseases as well. Then, during this, we started another study in which we started studying peripheral growth factors of autologous peripheral rich plasma. I would also add here that platter rich plasma, as Dr. Shadab mentioned, that it should be in a controlled environment. The centrifuge should be of certain capacity, and there should also be a temperature controlled environment as well, because during those rotations, what in ophthalmology the data shows that the rotation per minute should be almost to 2500, and you should do it at a temperature of 5 degrees. 4 to 5 degrees. Reason being that when there is a rotation, protein got denatured, and that is not
There is friction and heat
because
production.
of that. So use those gadgets which are helpful. अगर आपने centrifuge use करना है तो वो करिए जिसमें एक temperature control है,
Should be refrigerated one.
and the rotation per minute should be more than almost 1800 to 2500. The second study was on peripheral growth factors. We injected almost 30 plus patients, and this data is not that specific. Reason being that I try to explore other patients as well. For example, as I just mentioned, that those tyrosine kinase receptors are around the optic nerve, around the muscle insertion, at the perilumbal area, uvascular through as well. For example, I took a patient of Stargardt disease, retinitis pigmentosa, cone rod disease, open angle glaucoma patient, and another I tried this on patients who had RD surgery, and after RD surgery they don't have improvement in their vision, because that is a disease of peripheral retina, outer retina as well. So I tried on them as well. So these 30 plus patients are not that specific to retinitis pigmentosa. This is basically the patients of retinal dystrophies, open angle glaucoma, traumatic optic neuropathy, compressive optic nerve lesion, and RD patients. So this is my out of from first study, out of those 10 patients, this is the data of 8 patients. 2 patients lost to follow-up. The green shows the improvement in the vision. Red shows there is no improvement in the vision. The good thing is that there's not even a single complication, not even a single side effect we had during the procedure. You can see that these all patients are from retinitis pigmentosa. Initial vision is if I take an example of first patient, 660, 690, goes to 618 and 644. This was a patient who encouraged us a lot. This is the patient from which we got. Sorry? Sorry. Initially, we started what I think now that the age should be between 18 or 15 to 45 or 50. At that time, it was not that age specific because I was trying something new and I didn't know that how will it affect. So initially, you can see that in green color there's improvement in the vision, and in the red there's no improvement. But there wasn't any single patient who said that my current or my actual vision is getting deteriorated. ये पेशेंट वो थे जो सारे रेटिनाइटिस मैंने पहली जो स्टडी की वो मोनोन्यूक्लियर सेल्स के साथ आरपी विजन की इंप्रूवमेंट कितनी है और जी इसमें आपने सिर्फ विजन में मैंने किया ठीक है उसमें नाइट विजन में मतलब बिकॉज़ आई कुडंट क्वांटिफाई दैट मोमेंट आई पेशेंट्स वर नॉट जस्ट सेइंग कि हमारी नजर बेहतर हो रही है जैसे लोगों ने पेशेंट ने मुझे आके पहले बताया कि मैं ड्राइव कर सकता हूं मैं मोटरसाइकिल चला सकता हूं मैं बगैर टॉर्च के अब चल सकता हूं मुझे रंगों का पता चलना शुरू हो गया इसमें हमें विजुअल फील्ड भी कराना चाहिए जी बिल्कुल मैं भी शेयर करता हूं फिर हमें थोड़ा सा पता चला कि हमें कैसे करना चाहिए दिस वाज द फर्स्ट बिकॉज़ दिस वाज द इनिशियल क्राइटेरिया we start narrowing it down with the passage of time. This is data from the second study in which we started studying PRP, which was in a controlled environment, and we injected again in a subcutaneous place. We had planned that this injection should be with an interval of 3 weeks for 3 times. This is what we call loading dose. कि हमने हर 3 हफ्ते के बाद 3 डोजेस दोनों आंखों में पेशेंट को दी और उसके बाद फिर क्योंकि ये जो प्लेटलेट रिच प्लाज्मा और ग्रोथ फैक्टर है, this doesn't last long. It is for the time for a specific period of time. उसमें अगर टिश्यू या सेल हील करते हैं तो फिर वो ठीक फंक्शन करना शुरू कर देते हैं, वरना फिर वो टेम्परेरी या मोमेंटरी इंप्रूवमेंट लेके आते हैं. So we planned it for 3 sessions, and after that we increased the time span between the sessions. This is what we planned. And if you can see the diagnosis in these patients, one is RP, Stargardt, RP. This RP patient had a keratoplasty as well. This patient got referred to me from I guess it was from a far-flung area. This patient was glaucoma, RP plus glaucoma, RP and with nystagmus. Again, few patients had those nystagmus, and that nystagmus went away after injecting, and there was improvement in vision as well. The patients in blue color, they didn't have any improvement. Akmal Saab had optic atrophy after a traumatic lesion, and I tried it on him as well, but there wasn't any improvement in that. So this is a visual field of a RP patient. This is pre-treatment and this is post-treatment. Can you see the difference between the two? Can you appreciate that? There is a difference. And I must say that it might be not that significant, but there is a difference. Out of nothing, if there is some improvement is there, we got an idea that कुछ तो काम हो रहा है इसमें. Again, pre-treatment and post-treatment. Can you see this black area got starting grayish, and this increased here and here. So there was improvement in visual field of the patients. The second thing which Dr. Amin Usman from Anta University observed, that there's an increase in outer nuclear layer of the patients. I don't have those specific gadgets to measure the outer nuclear layer, but what I felt, what I got, that if you see the macular map in this is the pre-treatment, is the post-treatment of the patient. 160 and 210. There's an increase in macular thickness as well. So I took it as if there's increase in outer nuclear layer thickness.
सर ये सॉरी टू इंटरप्ट यू, ये जो सर ये कर रहे हैं तो इसमें अभी ये एलिवेशंस हमारे फॉलो पे हैं
जी मेरे को
और ये इम्प्रूव कर रहे हैं व्यू सीरीज में आल्सो राइट.
अभी मतलब after the treatment, what I observed, that from where you start, there's a jump of 1 to 2 or 3 steps. For example, if you start from PL positive, patient gets to counting. If you start from 660, patient gets to 636, 624. जिनको improvement आती है. लेकिन ऐसा ड्रास्टिक चेंज नहीं है कि अगर पेशेंट 660 और पीएल है तो वो 66 पे चला गया. टाइम विल कम इंशाल्लाह इन फ्यूचर जब ऐसा भी होगा, लेकिन अभी मैंने ये ऑब्जर्व किया.
अच्छा सर, इसमें जो आप ये है कि आप आफ्टर 3 वीक्स यू आर इंजेक्टिंग वन, यू आर इंजेक्टिंग वन, यू आर इंजेक्टिंग वन, तो ये जिस तरह पीआरपी कराती है उसके लिए आफ्टर फ्यू मंथ्स एंड यू सपोज्ड टू रिपीट इट अगेन एंड अगेन.
I just mentioned that if you are working with mononuclear cells or stem cells, the advantage in mononuclear cells or stem cells is that this time span is very long. What studies put up that if you inject stem cells somewhere, they are there for 3 to 4 years or even more than that. But if you inject PRP or growth factor, they work for 5 to 6 months after the loading dose, and after every 5 to 6 months you have to re-inject. One aspect. Other aspect is that the cost is very different. In stem cells, it's a bit costly, but if you go for growth factor or PRP, it's not that costly. So again, you have to.
So that basically that is the difference between gene therapy,
Gene therapy and stem.
stem cell
Yeah.
therapy.
Yes.
Because that is supposed to be more permanent, isn't it?
Yes, sir.
That is more permanent. This RB65 gene, you must have read about it. It is injected subretinally down the brain vitrectomy, and then it was very promising. You know, I sent one patient across to California. This was like 1.5 years ago. They're very rich people. I don't want to name them, but it cost them 10 crores of rupees for one eye. So that is the difference.
Yes.
But my question was, in so far, whatever your follow-up has been, what has been the sustainability of your, treatment? This is very important to know.
Because then you have to do it like after 6 months, repetition after 6 months, maybe a year. If you can sustain that even longer, then it's a far more, cost effective than gene therapy.
You are absolutely right. So that is what so far what all those this is lot of feedback. The point is that all those colleagues who are working with those patients have got a very gross visual loss, maybe up to EL positive, or sometimes head movement. You may appreciate, or you may not, I'm sorry to say, that if this region becomes a counting finger, only counting finger at 6 inches, this is just like that patient comes back to his life. This is the minimum amount, so much minimum improvement in vision. All of us should appreciate this is a lot of work, and this is just this is health. This is just this is just opposite to this. One must appreciate that this so little improvement in vision is so, not only psychologically, but actually, if the things become, when you say that one line improvement, this is a lot of it. And as you said, if it is sustainable, and this is very miraculous. And I think we should appreciate not only by saying words, but practically as well.
My experience is the contrary. My most thankless people are the ones, cataract patients, for example, whose free of vision is like numbing fingers or hand movement. And on post-operative vision gets very down to 6-9. But they are not that healthy. I'm not sure.
I can second you, but
Sir.
He said, why not I see the last line was actually 5 by 6. And you did explain to me that I'm going to have it very important. This is about forget.
मैंने ऑपरेट किया था, he was having hand stage glaucoma and hand movement vision. Then he improved. He was very much thankful. वो कहता डॉक्टर साहब अब क्या है, अब ये मैं आँख के पास करता हूँ तो मुझे कलर्स नजर आते हैं. So this is something he has improved and he was so much thankful.
इरफान ये बताइएगा कि जो फैसिलिटी पे आप बात कर रहे हैं कॉस्ट इफेक्टिवनेस की, so what is like in terms of, like he's mentioned a figure, so what is the figure like in terms of his cost effectiveness? So I know the gene therapy implies cost, so having this every 6 months or a year cost just for a trade.
How often should we gene? But the difference between PRP and stem cell is PRP is just the growth factors. And what it does, through chemotaxis and cytotaxis, it attracts the mesenchymal cells to the site of injury which do the repair. But when we inject the mononuclear cells, that is a cocktail of different cells. It contains, especially when we talk of vascular fraction, which we take from adipose tissue, it contains both mononuclear cells, which are called stimulatory or stem cells. It has progenitor cells. It has oligodendrocytes, all those things which are required, and plus the growth factor. So when stem cells are done, our experience in 2014, October 2014, we did our first section of knee arthritis. That patient didn't need any restriction. Same is with our case who are of history for cyclic case, only one stem cell treatment, but before that, the physiology is with every chronic condition and even with advancing age, the number of stem cell count decreases in the body, plus the quality of that falls. If we take directly the stem cell, we will not take the good yield, the count will not be good and will not have that much of quality cell. For that, we give 2 sessions of PRP 5 stem cell treatment. That will give, is just like preparing the land before sowing the seeds. So it will give us a good cultivation and good harvest. So once that is done, then what stem cells do initially, their function is to stimulate the already weak cells. They go to the site and by again chemotaxin and cytotaxin, they stimulate the function of weak cells. They stimulate them, and then for the first 3 to 6 months, they keep on giving rise to their own daughter cells. When they reach a peak, then they start transdifferentiating. Then they go to asymmetric cell division. And this maximum benefit we get in between 6 months to 1 year. The initial benefits which have been documented in this study are primarily because of the growth factor and indirect effect of the stem cell. The actual effects, they come in 6 months to 1 year and they last for years to come. So
What is the cost? What is the
so
cost?
coming back to the cost.
I think that's a marketing.
Yes. Cost is using good quality PRP kits and doing it we can do it with 800 kit or even in 50 rupees test tube, but the problem is we will have no clue whether we are using platelet rich PRP or leukocyte rich or leukocyte poor. And we will give leukocyte rich will always damage the patient. So a good kit costs around $80. And so what we charge around is around 30,000 for PRP, including physician intervention, paper, and for stem cell. For kids and especially this disabled kids, we are doing a non-profit work. Our cost is around 150,000 for all the kids. But we charge for 40 patients, we charge half.
I must add here that
Conflict of interest.
I must add here that Dr. Shidar encouraged me, and he's kind enough that he supported this study of first 10 patients, and he did it free of cost. That was something which. So then we started further studies. मेरी भी फिर इतनी की चार्ज ज़्यादा चार्ज नहीं कर.
Because we have many patients of like transplant who are waiting for such treatment.
Sir, we can even reduce it to minimal. मतलब उतना भी कर सकते हैं ताकि जो पेशेंट्स इनको सपोर्ट चाहिए हो.
Non-affording,
For them
we will do it free. We will do it free. For partially affording, we'll do it cost to cost, and for affording, definitely.
और जैसे डॉक्टर रही कह रहे थे और आप कह रहे थे, I think the improvement of home care that you talk about is like gaining personal independence. अगर आप खाने की प्लेट में चमचा देख सकते हैं, वॉशरूम तक जा सकते हैं, चेहरा पहचान सकते हैं, this is totally like different.
Sir, I have testimonials of patients of that patient from Sahiwal. He was open angle glaucoma, and when he came to me 5-6 years back, totally blind. Single earning hand, and he was very suicidal, everything. But now he's driving his motorbike independently, running his tune
We
shop.
have treated that patient, and mashallah, he's very happy. तो जब भी आता है भाई के पास
If you want, I can share all the testimonies in my
Yes,
laptop.
sure. We can share all the videos.
Yeah.
So मैं बाकी videos भी share करता रहता हूँ.
थोड़ी सी मैं भी मार्केटिंग करता हूँ. Ophthalmic Research and Education Foundation is in place, so you can subscribe to futuristically to develop that organization. So you link up and bring it up.
Sure, sir.
If you are there with this solid project, they should fund it.
Sure, sir. And again, I'll just complete my presentation. Dr. Faisal just asked that can there be some pain in cystic spaces in the macula, on the OCT, or like liposuction deposits under the retina? Yes. If you search Dr. Amin Ukbar's work, he's a professor in Ankara University. He basically started this idea 2 years back, and I'm just following his footsteps. In his work, there are a lot of OCTs which are showing that there's all those liposuction deposits and all those cystic spaces are gone. So far, we haven't got that much of confidence कि मैं उनको भी try करूँ. पेशेंट को पूरा काउंसिल करना पड़ता है क्योंकि पेशेंट ने कहीं और नहीं सुना हुआ कि ये काम होता है. वो कहते नहीं डॉक्टर साहब और तो कोई कर रहा नहीं, तुसी कितना कर करोगे. मैं इतने नहीं कहती ਤੁਹਾਡੇ ਬਾਲ भी कर नहीं. I just फिर सबको you cannot explain to everybody that this can.
And one more, but they are sufficient.
कितने वाला नहीं बिक रहा था. Again, change in macular thickness.
इरफान इसके साथ जो आप ये ठीक है मैपिंग और थिकनेस सर इसके साथ क्रॉस सेक्शनल आप सीटी लगा के उसकी थिकनेस वहां नहीं शो कर
सर आप जी बिल्कुल मैं नेक्स्ट अपनी when this will got more refined and things would inshallah develop and get better. My limitations were that patient selection criteria was not that strict because in all the international studies they take patients better than visual acuity better than 660 and there's no other comorbidity like cataract, glaucoma and all that. And again that they have certain limitation in visual field and all. We started with working on patients which had visual acuity with far more less than that, visual field far more visual loss was far more greater than that. But I personally think that the further when we start working on it more, then we will further limited to a certain patient of in which the results are better. But in our settings, मैं समझता हूँ कि पाकिस्तान में बहुत सारे पेशेंट प्रेजेंट ही तब करते हैं या आरती का पेशेंट प्रेजेंट ही तब करता है जब उसका विजुअल लॉस बहुत ज्यादा हो गया होता है 6, 12, 18 में तो वो इसको समझता है कि नॉर्मल है. We should start teaching or encouraging those patients to get treatment so that they can get better back in their normal life.
So वो आपने comment नहीं किया night vision और day vision.
Yes, sir. My comment is that there is improvement in night vision. There is change in multifocal reality. There is change in color vision as well. Patients start appreciating colors. They have good night vision after the treatment. Any questions?
मेरा ख्याल है excellent we actually need more class
Professor Nadeem Jawad is there. He's my teacher. He's my supervisor, and I'm really honored today, and I'm so happy and proud that he's here today. And
So am I actually. It's so nice to see you thinking on those lines. And really, we were both discussing that we should encourage you in whatever way we can. Inshallah.
I just want to ask about the corneal condition, the role of stem cells in improvement of the cornea, which is like in those patients in which there is already a loss of stem cells. We have been doing it like by any kind of transplant from the good eye or even from the blood vessels having the same blood group. But is there in your opinion or thinking that we could use this method for any improvement by injecting it around the subcutaneous or any way used?
So I must insist that we should go for it. Reason being that it's harmless. There are a lot of patients there are studies for the patient of Stevens-Johnson syndrome, and people are having very good results with autologous PRP. Given yes, sir, and given Sapinon. And if there is a corneal disease or corneal issue, we should go for it and we should try.
So we use this already prepared serum or whatever you call it, and the patient having the same blood group, so that we cannot. We are not going to do all this procedure to the patient and with that cost of all the kit. If you've got a spare 0.2 ml or something like this, we can ask the patient to come and inject it if it is of the same group.
So there would be a lot of ethical issues with that.
Saving the just giving an injection in subcutaneous type of patient may not be able to pay this amount of $500,000. We can have
This PRP will not cost $500,000. PRP will just cost around, if we just charge of the kit, it's $80. Around $15, $16.
Up to the point is even if to ask the patient we are going to improve the aspiration and going to improve this and this will cost so many thousand, even then they will think you are right. So if we can have a spillover after
I offer if you I offer we can collaborate that we'll provide all these services free of cost to all the patients who are desired. Right? So it's where either you can send it to our center or we can send our team. You collect the patient, they will take the sample, they will do everything and will be at your center. We are ready for any collaboration and it will be free of cost.
Have you tried via the suprachoroidal route? First, my first question. And second is, have you injected all the patients at the same site where the cells were prepared? And if not, then how do you transport it? How do you maintain the cold chain?
First, whenever we prepare it, we inject it within 2 to 3 or 4 to 5 minutes. This is the lab, in the lab, and for PRP, the setting is very close. Rather, we do not even take 1 to 2 minutes to change the vicinity. For mononuclear cells, we have certain containers which help us to ship from the lab to that vicinity. So this is the way we transport it, and because we are doing it in the same vicinity, so the cold chain doesn't disturb. Second, that yes, I use the same site. For example, if I personally prefer, according to the all the studies, that I prefer infotemporal or info-nasal quadrant, and I go almost 8 to 10 millimeter from the radius. That is all there in the studies. You can read that, and I exactly follow the same rules. And I go in the sublingual space and I inject that. Third, I never use suprachoroidal. Reason being, I tried it on a blind eye, but I personally feel that it's invasive. If you cannot, the benchmark is that if you cannot give any good to the patient, please do not give any harm to him as well. So I just try not to be less invasive. Which if the फायदा अगर कम है तो कोई बात नहीं, नुकसान भी तो नहीं. This is what the.
We used to custom both of you in very severe dry eyes, which were on the border of getting filamentary keratitis, which was really resistant to everything. And we used to give somebody came to a scientific conference and they suggested you make autologous serum and you make eye drops from that and give it to the patient, and it was a dramatic change in the what was that? What were we doing?
It's only sometimes.
No.
So start getting them.
It's not only the autologous serum. If you make it from the umbilical cord, it is even more effective.
So what was it? You can comment it on expert.
Platelet plus plasma contains matrix and proteins. So those proteins basically help in matrix formation, and I'm not familiar with the eye because we had an internal professor who just used to ask us, don't go into eye, I will pass you.
No names. आपका catch क्या है?
सर मैंने persistent epithelial defect में ये यूज किया, मैं खुद ही बनाता था ये, और इसमें सिंपली ये जो ब्लड सेल लेके ना लेबोरेटरी वालों को भेज देने के इसका सीरप बना, उस सीरप को सर नॉर्मल सलाइन के साथ में या तो 20% में या 50% में उसमें वो डाइल्यूट कर सकते. मैंने ये किया था सर कि जो persistent epithelial defect के पेशेंट थे ना, तो उसमें वो 100% मैंने उनको दे दिया, तो वो
डाइल्यूट नहीं किया, फ्रिज में रख लेते थे
उसको, सिंपल फ्रिज में जो है ना सर, ये तकरीबन उनको बता देते कि महीने तक ये एक्सपायर नहीं होगा. अगर आप उसको फ्रिज में रखें, आपने उसकी बोतल के ढक्कन को पैक नहीं करना, और उसमें ये था सर कि जो बोतल है ना वो ऐसी हुई थी जिसमें से लाइट पास ना हो, जैसे एल्केन वाली, तो वो एंटीबायोटिक वाली बोतल खाली करके सर उसके अंदर वो मिक्स कर दिया उसको, तो वो 100% बना के उनको दे दिया, और उनको कहा कि बाल आप यूज करें. वो स्टिंग करता था, चुभता था आंखों में उनके ना, लेकिन ये है कि वो तकरीबन उसमें से मैंने 14 पेशेंट से ट्रीट किए थे, और 14 में से 12 के करीब ऐसे थे जिनका वो परसिस्टेंट एपिथेलियल डिफेक्ट पता नहीं कब से वो लेके फिर रहे थे, वो हील कर भी काम कर सकते हैं. और ड्राई आई के लिए उसको ना सर उसमें ये तो उसको डाइल्यूट करके दे देना, तो वो दैट इज बेटर.
Sir, I would add in it as well that in dry eyes, electrolytic plasma or serum is working very well. There are studies which are proving that Sapinon, real Sapinon injections of 1.5 to 1 ml of serum they work miraculously. You don't have to keep them for long. मतलब ड्रॉप्स में तो आपको बार-बार ये एक बार yes definitely already studies are published. Studies are published already got published. There is a lot of data on it. I'll share it with you as well. I'll take
injection at 8 millimeter distance. Olympus is taken as material Sapinon.
Sir,
it is better to go a little bit discreetly and
sir, what I follow is that there are 2-3 different ways the way you inject it. I make a nick there, and with the help of a blunt cannula, I went from that nick to the posterior more than I injected.
That is actually posterior Sapinon.
Yes, that is actually posterior Sapinon. That is how you
also, I think you remember I was suggesting that if we can inject this suprachoroidal by making a small radial incision, just like we do
small space and injected and immediately tie this. It would be, I mean, less invasive as is to making it full 5 to 5 millimeter.
You're right, sir, but then try once sucking on, once try sucking on, and you'll come to know that the difference is not that much. So why not why get to get in this? I'll take this opportunity to announce that, sir, please give.
What is your marketing? No, it's not marketing, just to make it awareness and
Access.
to make it more ethical, right? So, I mean, it took us our age to become a specialist in one field. So, regenerative medicine is a supra specialty. So, we should not take it for granted. We should have a centrifuge, we should have glass tubes, and we should start doing it. We should know the basics. What is PRP? What are all those things we discussed about? And so we have formed a school. Ifat, Ruxana, my mother, and Irfan's mother on their name. And theme is from bench to bedside, because we all know lots of PhD students are working in School of Biological Sciences, Center of Excellence in Molecular Biology, everywhere in public and private universities. But nothing is transforming into clinical. What we are trying to do is, my personal experience in 2014, when I came back from Germany after my fellowship in regenerative medicine, I went to School of Biological Sciences and said that this is what we were doing in Germany, now we want to do it, and we want you should culture, and then we can differentiate them accordingly. And they started laughing at me, all those research scientists. But now, alhamdulillah, we have a team where we have research scientists who are PhD, postdoctorate have done from UK, USA, and we are working together. So the basic idea is to translate fundamental discoveries which are made in lab into innovative and practical clinical applications that will enhance the understanding, diagnosis, treatment, and prevention of many human diseases, including ophthalmology. Right, so this is the faculty. We have local and international people who have put their lives into this regenerative medicine. Professor Sudhir Diwan from USA, Chris Paulus, he is president of American Board of Regenerative Medicine, Aggie from USA, now practicing in Hungary. So many people. What we are trying to plan is a 3-day weekend course, which will be called Certificate of Basic Competence. Then we can go for advanced courses in regenerative medicine, and then postgraduate, including MScs and PhDs, inshallah. Right? For this basic course this will be 2 to 3 days to understand what are the plasma growth factors, to extract the plasma growth factors from the blood, to assess the patient and prepare the treatment area, to apply a proper injection technique like with ophthalmology, Dr. Irfan and other people, they are into this. Okay? Topics discovered will be plasma growth factors, which are important, which should not be used, indications and contraindications of PRP, pre-treatment and post-treatment instructions to the patient, patient education, all those things, injection techniques manually or with the device, leukocyte rich, leukocyte poor. This is the key, where to inject which one, right? So it will have didactic course materials, live sessions with instructors, hands-on practice on live models in small groups, and we'll also tell them how to start your PRP business. And then the advanced courses in future. So this is, my request would be, please do it, but do it after learning appropriately. Otherwise, आपकी पूरी जिंदगी के मिलियंस ऑफ पेशेंट्स की नेकनामी और एक बदनामी सब पे पानी फेर देती है. Sir, inshallah, Irfan will share with. This is just the idea, and with the permission of Professor Mui, he allowed us to हम इसको कम से कम बता सकें उसके बाद जो है. And sir, your blessings.
So glad मैं तो गाइड कर रहा हूँ. Very engaging. Irfan साहब के साथ एक पिक्चर लो.